Paul Karpecki will be our next speaker. He received his Doctor of Optometry degree from Indiana University and completed a fellowship in medical cornea at Kansas City in affiliation with PCO. He currently works in corneal services, heads the Ocular Surface Disease Clinic, and is Director of Clinical Research at the Koffler Vision Group in Lexington, Kentucky. Author, Dr. Karpecki is the Chief Clinical Editor for the Review of Optometry Journal. He is past President of the Optometric Council on Refractive Technology and serves on the board of the charitable organization Optometry Giving Site. Paul, welcome and thank you. The floor is yours.
Thank you, Greg. Wonderful introduction, and certainly it was great hearing Dr. O's presentation. I've been fortunate to have known him for probably close to 12 or 14 years. He's always been a great leader, and certainly always looked to him as one of the true, experts in that field. And so his insight and his research is something that I really have always been impressed by and have always trusted. So it was great to see him coming through with this level of research. I'm going to take you through a little bit of really our role in optometry. And as far as the company, Arctic Diagnostics, they of course are based out of Toronto. I have a little background of that. I was born in North Bay, Ontario. That's my connection there, and I went to school in the States, in Indiana. They have an office there in Grand Rapids as well, as far as the genetics and all the testing related to that. So they cover the U.S. and Canada. Now, this isn't anything new to anybody on this webinar, and we don't put it up there because you all know what age-related macular degeneration looks like. But I put it up there because I think that it really gives us a perspective of how important it is for optometry to be proactive, to not allow this to happen to patients, to understand the devastating results that this can cause, and to be extremely cautious in patients who may have already lost one eye in particular, that we manage them effectively. And that's why some of the work that Carl presented was so valuable. Like, for example, we have an increase in CFH genes and, no arms too, 135% increased progression with the use of zinc, and that's 13% of the study population. So back to our old adage of doing no harm, we really have to look at these things and make sure we aren't doing any harm now that there's new capabilities that are at our hands to be able to do it, prevent our patients from what we see in this example. And this is an important slide because when I went to school, in the early 1990s and mid-1990s, we were taught pretty much that you either had wet macular degeneration or dry. And if you had dry, we would tell patients that's the better form and there's nothing we can do. And we know a lot better now. We know that we actually have to be proactive and make a difference. We can assess the patients. We could customize vitamins. We could slow down progression. And if that was my mother or myself or anyone, I would certainly want a doctor who knew this stuff and could help. It's the leading cause of blindness in patients over age 65. 2 million new cases per year in the U.S. and Canada. Over 30 million in North America have macular degeneration, AREDS 2, 3, and 4. More than 7 million have intermediate levels. He talked a little bit about the importance of, the level as well and what it showed in over 10,000 boomers turn 65 every single day in North America, and that'll continue for about 20 years. Results in 600 new cases. CNV every day or wet development of macular degeneration, meaning those patients technically in most cases go blind in one eye. So we really do play a key role in this, and we see these patients, and they're really the ones we need to manage well, and they are primary care level. Now, current standards are really two options. So obviously at the bottom there, if it is a case of a retina specialist, standard care in the wet cases is going to be your VEGF inhibitor injections. So your anti-VEGFs, the Avastins, Lucentis, now Eylea, and even sometimes the steroid-type options. But for the most part, it really has become a standard for injection being the key to try and control the blood vessel growth as well as the swelling, et cetera. And we're seeing some great results if those patients are followed and caught early. As far as the top there, for the dry form, as we're seeing, the standard care had been AREDS. And we just went through a little bit of what that is. But now all of a sudden we start to realize there's more to this. And of course, just as a review, AREDS 2 ocular vitamins are vitamin E, C, and those are your antioxidants. Lutein, zeaxanthin, and although mesozeaxanthin wasn't in this study, I will mention here are your carotenoids that are actually found in your macula, so they become very important, but I don't put them down as antioxidants. And then your copper would be there with vitamin E and C, and then of course zinc at the 80 milligram level or 25, depending on the formulation. 80 milligrams being about 5 to 7 times the recommended daily dosage too. So I think that is important to look at. I'm going to put a slide in that Carl already presented on really well, but I want to reemphasize this as a take-home message that patients with two CFH risk alleles and no ARMS 2 risk alleles should not take the ARIDS formulation. So again, back to this do no harm approach. If we know the genetics, we can customize what's going to allow this disease to hopefully, and it's been shown, to slow progression of the disease. But we also know that based on genetics, we could increase progression as much as 135% in some cases on things like zinc. And so it's interesting to look at that. Genetics really make a difference. And I guess that's not so surprising when I hear it. But it's fascinating to see the impact it has and how you can look at the numbers and analyze it. And the work by Joanna Seddon and Carlo really made a difference in I think how we will all manage this disease today and especially continue to going forward. And I think that's really the proactive approach I'm trying to get across today. And it really will make a huge difference. We're going to personalize the medicine. We're going to change the way we look at eye vitamins. It's not going to be one size fits all. And it never normally is in most cases of anywhere in medicine where the same treatment works in every single patient the same way. And now we understand that some areas could even be harmful depending on your genetic makeup. So the overall, if you look at this prone here, how recent genetic analysis really have shown it can be harmful or helpful, as we talked about. And the answer really does lie within your genetics. So this slide was also important. What this really shows is a couple things that I think are quite important. And that is, if you look at at the top, the CFH risk genes, none of them 1 or 2, and then the ARMS 2 risk genes. So basically what this shows is that zinc increases progression risk in patients with the CFH, and that's what we're looking at in there. And antioxidants increase progression risk as you move on the opposite direction. There are ARMS 2 risk genes, the 2. So, and you can see this by the slides, and these were presented, but I like to kind of get to the opportunity to hit the take-home. So in green is zinc only. So a person who has no CFH risk genes and 2 ARMS 2, you can see that in essence, the placebo is up here in the purple. Actually, the placebo goes right over top of the zinc plus antioxidants. So if you're wondering why there's only looks like 3 in that first graph, they were actually right in tandem and overlap. You're able to see that over time, the progression changes that occur in that group. And so as mentioned, there's a percentage of patients that truly do benefit from zinc based on those genes. But in other patients where you've got, the CFH risk present alleles here of 2 and no ARMS, you actually could have a progression, as mentioned, as high as 135% for 13% of the population that have that genetic makeup. And so it really shows you that based on this, you can predict what is the best approach for patients and customize it. Some patients really shouldn't have antioxidants and some shouldn't have zinc. And so we have to be able to put this together. The one that, again, I emphasize is the fact that the carotenoids found in the retina are not considered antioxidants for the purposes of this. So your luteins, your zeaxanthines, and mesozeaxanthines certainly, I think, are beneficial. So there's 2 options in terms of being able to test for this currently and look to see, first of all, the first test, the NXG, or macular risk, I should say, that's how I've known it as, will tell you your risk progression of vision loss, who's more likely to lose vision. And what's really valuable about this test, one, if you look at the 5-year predictive value of 0.883, remember as you approach 1, you're getting high statistical analysis, and 10-year 0.895. Those are high numbers. But the thing that's so valuable for me is it helps me know with talking to patients about the importance of compliance and doing everything we can. But I think more importantly, if I know a patient has a high risk of macular degeneration progression, and that is the potential to go too wet, and go blind, I'm going to see that patient more often. So it gives me the exact model to know when to follow up a patient. At the really high risk, it could be as soon as every couple months, believe it or not. In a person who tests very low risk, I feel a lot more confident that if I only saw them every year, I would be okay. So, and there's a lot of factors that play a role, of course. It's not just that kind of drive, but it is very important to me, to the management of these patients, and knowing that ability in terms of the follow-up and optimal management. We finally have a test that tells us that. And then there's VitaRisk. the ARIDS pharmacogenetic, which actually tells you the customized treatment for these patients. And this is all the work that Dr. O presented so nicely at the beginning of this webinar, that you could look at the CFH and the ARMS2, alleles and decide which patient should be best served by zinc, which one should totally avoid it because of the progression risk. Same thing with antioxidants. So this involves a cheek swab. There's the form that is used. In the U.S., it is insured. In Canada, it would be a patient pay. I have an amazing number of patients, though, tell me that, they would pay for it just to be able to know the results. But just in terms of the risk, pull up and what's involved in that. So in the States, we have to have the presence of drusen, the presence of risk factors, and then at that point, it becomes insurance covered. But we can look at this for the macular risk, PGX, full prognostic results and vitamin recommendations. And there's also VitaRisk, which also gives you your genetic score and vitamin recommendation. And I think that's so important. You not only want to know what the risk is. So we look over here, we have an MR4 out of MR4 versus 5 is the highest. But any MR4 or 5, I have to follow that patient quite closely. That is a very high risk of progression and vision loss. And I don't want in 6 months or a year saying that they've got hand motion vision when I know based on their genetic progression risk that I could see them every quarter or maybe even every month or two, depending on if it's an MR5, for example. But this is an MR4 level. I'm certainly going to see them at least quarterly. And then we go to the right, and you can see that the treatment recommendation tells you that if you included the antioxidants, vitamin C and E, you'd have a 60% progression reduction over placebo. That's, again, based on the CFH and ARMS2 genes, or alleles, I should say, that are present. So it tells you not only your risk and follow-up frequency, but then how to optimize your treatment for these patients. What a wonderful thing to be able to show a patient, and how many doctors can do this. And I think this is the future. You're just in a neat situation to be the early adopters to make a difference for your practice and for your patients and be able to show them this. And I tell you, they will tell a lot of their friends and family because no one else is doing it. In fact, if you look at the VitaRisk patient report in this one example, as we talked about, by taking the antioxidants of vitamin C and E, we had a 60% progression reduction. But if you look to the right of it, you actually had progression, not reduction, but progression or advancement or harm to the patient if they took zinc by the negative result there, minus 5% or whatever it may be. But it just shows you that in terms of the risk factors. Here's a patient who would be much better served not with an ARIDS formula, certainly avoiding zinc, but with an antioxidant supplement. And I would still include the carotenoids in there because I just think that having lutein, having zeaxanthine, and having mesozeaxanthine, which are already present in your macula, I believe make a big difference. So I still include those in all my patient treatments, and we'll talk more about that. So here again is a report that goes through the genetic risk score. So this is telling us, based on all of this genotyping that we can look at and see the results that come through just from that cheek swab, that this patient's generic risk in a percentile formula is just about 80%, meaning 79.93. That means their risk is higher than about 80% of the population. That's a great number to know. If I was that patient, I would trust this doctor and be there on a very regular basis, knowing the risks and blindness that can occur. And that's why I showed you that first slide with the missing central vision, because I know we all know what the results of AMD are, but I think it just kind of emphasizes then putting it all together with the scores. So if we look again at this publication, of course, I can't do it the justice that the author himself, we were fortunate enough to have on this call, provided, but more than double efficacy of supplements in terms of these patients. 23% did best on ARIDS, 13% did best with zinc, 36% did better on antioxidants alone. So it tells us, a lot about what's going to work best in these patients based on their genetic polymorphisms and the prediction that lies within knowing that. And there are about 10 manufacturers up in Canada that do provide ARIDS type formulations. Fortunately, the one I use in my office is MacuHealth, the number 3. And that is, so I can talk to that one since it's the one that I utilize. And I kind of like, and they're all good. I mean, I think once lutein came in, we had a great advantage because that really helped with finding a pigment that's already present in the macula. And then I take this from Dr. Dennis Ruskin, because he provided really insightful when I talked to him a few times. But then, that would be good. And then you go to better, and that would be, for example, the zeaxanthine addition. And then best might be with mesozeaxanthine, the third added to it. It doesn't mean they aren't good, all three, but you can go better and you can certainly go best. So I do like the ability, though, to have a product that has zinc or not, as we just talked about. We had increased CFH genes and no arms too. That's not a patient I want on zinc. So I'm going to make sure that I have the option to do one of these formulations without the zinc. And so on the right, the MacuHealth product, you've got your vitamin C and vitamin E. And in the example we showed you, those patients would do very well with this. And again, I'm a real big believer in the carotenoids of lutein, zeaxanthine, and especially mesozeaxanthine. I think that combination really makes a difference. That's in the gel cap. The other one comes in a tablet. And then I could look at zinc. I'm also, looking at the ARIDS. This is my own personal opinion, but I looked at the data there very closely, and there's others that share this. But when the 80 milligram hyperdose was compared to the 25 milligram dose, and both of these are above the recommended daily allowances, there didn't seem to be any difference in the patient. So I tend to prefer the lower dose in anything where there's no difference in results. And so I kind of like seeing a 25 milligram present as opposed to 80, as you see there in the ARIDS with the zinc MacuHealth formulation. Again, there's a lot of products. There's 10 of them out there that have some capacity to treat based on an ARIDS type formulation. So you got to look at this totally different than we did in the past. We got to look at it from the patient standpoint. Zinc is harmful for some patients. 13% to be exact will actually progress over 130% more than they would not on zinc. Improved outcomes through personalized patient care, the opportunity for improved patient compliance. Patients love being able to say, wow, this is something specifically based on my own genetics. And we know that if we look at the data presented by Dr. O, that we can choose the best combinations that'll slow down this awful disease the fastest. And it's good for the practice. Practice looks very progressive. The supplement market is still very positive. It does very well for these practices. I know with MacuHealth in my office, it has been wonderful to be able to provide something that I know works well and believe in for these patients, and the convenience of having it. And AMD detection and prevention, I think, is the most important reason we do this anyways in terms of saving sight for our patients. So what do we do as far as who tested? Well, the technicians do pull charts and they check for patients on supplements. In the United States, to get an insurance coverage, we have to have a drusen present or some early AMD signs at the minimum. And then the cheek swab is conducted by the staff. Sometimes even the patient. I usually have my technician do it. Then the doctor signs the test request form, reviews the report, and then based on the results, as you saw there, you can choose the supplements. It's a wonderful discussion when you have the patient in front of you and you can look at the data that's provided by VitaRisk and the Macular Risk, how often we need to see the patient, but also the VitaRisk and say, this is the ideal treatments and here's what I'm recommending. And this we know, based on this great research that's coming out, is most likely to slow progression of this disease. And their patients do light up when you have that opportunity. So it kind of breaks down the two options. So AMD treatment, personalized ocular supplements. There is safety issue with zinc. We talked about the do no harm. Identify the 25% who will benefit from an ARIDS formulation. Will improvement in compliance. That's definite. When patients have invested in getting this information, it's rare for them not to follow through. And I think then we're really saving vision. And that's good for the patient, it's good for the practice. There's a number of formulations out there. I happen to have experience with the MacuHealth, so that's the reason I put that one in as the choice. Because it's the only one in that list I've used extensively now for over a year. And I just think I've had wonderful responses from patients in terms of what I've seen in some of Nolan's work. Really reemphasized the value of those carotenoids combined with then the genetic predictions of the ARIDS type formulations with it, that is with or without zinc. And again, only available through eye care professionals. I think that's very valuable for the patients, convenient. They know they're taking what they should. And I'd recommend you consider doing this. I think it'd be a great benefit for your practice, but most importantly, for your patients. This is really the time optometry can, as a primary care practitioner, gatekeeper for eye care can really make a difference in the lives of these patients. The patients that 20 years ago when I was in school, we were told, you're lucky you got the lesser of the macular degenerations. You got the good macular degeneration. Can we select things that can help? We can actually customize their treatment, use nutritional supplements, choose what we know is going to benefit the patient, and avoid some of the harmful ingredients that are fairly prognostic based on the genetic makeup of your patient. So with that, I think we will open it up now for question and answer. We're right at about the 10-2 time, which is what we were hoping to do. And if Carl is able to be on still, either one of us can answer any of your questions and would love to.
That's great. Thanks very much, Paul. Greg Hines here again, and I've got my cursor on the control panel, and we do have quite a few questions. So I'm going to start with maybe one for you, Paul, and we have a series of questions that are related around the MacuHealth product that you're using. And the question I think that seems to pop up is, according to Carl's data, there are patients that do very well on zinc. And for those patients, would you recommend the carotenoids along with zinc? MacuHealth, for example, in terms of the lutein zeaxanthine and mesozeaxanthine.
That's a great question. So if you, for example, you're right, there are patients where clearly this progression was slower on the zinc supplement. And that was really just they recommended the pure zinc. But I do believe the option of just taking the carotenoids has no downside and likely has an upside. And the reason being, if you look especially at some of the work done by Noland out of Ireland, read some of his papers recently, I really feel that he spent his whole life in this area just studying carotenoids and in particularly was able to identify the presence of those pigments within the macula of all three. So we know that patients who have those present do tend to have benefits. And it may not be related so much to progression. That's where, in that one example you gave me, that would be where zinc comes in. But I'm fascinated by how it does help them as you build up those pigments in the macula in terms of the patient's symptoms. Now, I'm not saying their vision goes back to 20/20, but they feel like they're contrast or they feel like there's improvement. And when I've done some contrast testing on them, after using the supplements for 3 to 6 months, I do tend to see that these patients do better. So I think there's a number of reasons that carotenoids make sense in patients with macular degeneration or at risk for macular degeneration. And it basically shows that a lot of the patients who do have progression and other issues tend to have low levels of the pigment. So there's no real downside in my opinion. We're not aware of side effects of those dosages. Been well studied. They're already present in the healthy macula. So you're able to just perhaps enhance contrast, maybe even a little in vision. But then again, the genetic testing combined with that will help slow the progression and kind of have the best of both worlds that way.
Okay, thank you. Another question, maybe Carl, this one might be fielded, it could be fielded to either one of you, but you talked about it at the beginning. The VitaRisk test tells us which supplement to recommend to our patients. What is the benefit to using the macular risk test? I don't know if Carl, if you're on.
Yes, can you hear me?
Yes, I can.
Okay. There are two main types of patients I now find I use this test. So for patients with moderate AMD who have not yet developed advanced disease, it's important to understand what supplement to recommend for them, but it also is important to understand which patients are at higher risk. Because at least in my practice, there's just not time to see every patient, every month or every 2 months or even every 3 months. If we had only one patient to care for, we could see them every day, but we're always trying to stratify. And so that allows me to identify the highest risk group of patients, and those are the ones who I will see more frequently and perhaps co-manage with their primary eye care provider. So we're sharing visits. They might not have to see me that often, but at least that higher risk patient knows us. They know where our office is. They sort of are ready to be plugged into our AMD. So I think that's the biggest reason is understanding the patients you're going to see more frequently, and as some of the data suggested earlier, patients who know they are at higher risk are more likely to be compliant. Human behavior is just really influenced by understanding risk. That's why we have warnings that make people wear their seatbelts more or stop smoking more. When you understand that something bad might happen to you if you're in a certain group, it changes behavior. So that's a very valuable thing for this test.
That's really well said. I'll just echo it one other area because I couldn't answer it better than that. But even for, some of your equipment like OCT, if you happen to have that, but if not, just for checking the macula, as mentioned, there's medical necessity of when to utilize that in macular degeneration patients, and should I do it every time? And again, as mentioned, the macular risk tells me not only the frequency, and I like the idea of co-managing with the retina specialist because then they know where to go should we see any signs of progression or wet development, but also that justifies the OCT testing a little more frequent than it would on a person who had a very low risk, like an MR1 or 2. I'm much more likely to do those tests on the higher risk patients.
Can I maybe just expand and cover a couple of questions that we've got here? We know that vitamin C and vitamin E are antioxidants. Are there other antioxidants that you might comment on that you might use as well? Or can you comment maybe even on fish oil, as the results were unequivocal in the AREDS 2 study? Either Carl or Paul.
I'm happy to address that first and then turn it over to Paul. As doctors, we're always making decisions with imperfect data. And so our publication and the one that is coming out really is based solely on an analysis of AREDS data. And so in AREDS, the antioxidants were considered vitamins A, C, and E, plus 80 milligrams of zinc. And these really significant findings that we have presented are based on the combinations of either AC or and E plus zinc, or zinc alone, or AC and E alone. So going beyond that really is just extrapolating from other studies and other research that's been done. So as we know, AREDS 2 showed that lutein and zeaxanthine in the place of vitamin A seem to lead to similar outcomes. So I think from that we might think that that group of nutrients, lutein, zeaxanthine, C, and E, might really substitute for what in AREDS, in our analysis, was called the antioxidant group. And the zinc dose in AREDS 2, we know they use 2 different doses. We really don't have access to that data. We don't know whether 25 milligrams of zinc would result in a different outcome than 80. And so is there a dose response with zinc? We don't know. And it may be a situation that for those patients for whom zinc is good, it's really good. And so you want that very high dose, or we may learn that there's a threshold at which we reach the benefit, and perhaps that benefit is as low as 25 or even lower milligrams of zinc, and we don't need to be giving the 80. So I'd say I can't recommend more than what our data shows us, but those who understand ocular nutrition more, like Paul, I think are comfortable, and I think it's appropriate to consider other substances that in other studies have been shown helpful for our patients.
That's a good answer. I'll take the fish oil one as well. And, in these patients who, in the AREDS study had pretty high nutrition levels to begin with, as a whole, so they weren't necessarily patients with poor nutrition or with issues. So we're not sure really of, again, as Carl said, we're making decisions on limited data, what their intake of fish and supplements in that area may well have been, or how it played a role. So when they did the fish oil supplement in this group and not showing any real difference, there was a lot of questions because it wasn't a high dose by any means. Not everybody did also take others, and so there was no kind of breakdown in terms of the patient. It was more of a, it was an ethyl ester form, which is fine. They eventually get the same concentration as your triglycerides, but not usually in the early stages. takes a little while to get there. So even though it was inconclusive, I don't think I think that's exactly what it was. It was inconclusive. I don't think it really taught us that there's a negative, or it certainly didn't show any harm. So, I think that the jury is still out on fish oil. I wouldn't have a leg to stand on to argue against its use. It may have benefits. In this one study, it didn't have, arguments to show for it. So I think but it was a neutral response. So I know a lot of doctors add in fish oil, and I can't fault that. There's going to be benefits to the ocular surface that have been proven, benefits to meibomian glands, benefits to, overall health in these patients. So there's really not a downside in that patient population based on the AREDS. And further study really is warranted to give us a true answer. Again, none of these studies were repeated either for us to really know in other scales or larger groups if power numbers could have been found.
Okay. Thanks, Paul. I have a good question from my perspective. Someone is asking, where can we send patients for this genetic test in Canada? And maybe the answer to that is to your optometrist or eye care professional.
Yeah.
Since there's a whole series of questions here, let me just, some of them are very similar, but sorry here, I'm trying to get through them here. How can practitioners get nutritional supplements into their practices to comply with the recommendations of the test?
I can take that one.
Okay.
So I think that fortunately most of the manufacturers in that list of 10 that was provided, and I thank Greg for that because I didn't know all of the manufacturers in Canada, so I had to get his help, and that was a valuable chart. But almost all of them are kind of aware of the zinc, non-zinc, at least in that group for the most part, not everyone there, but most, so that they are starting to base formulations on some of this information that Dr. Sed and Dr. O and others are providing. And so you're seeing that. And MagHealth had both versions. A number of the others do as well, a zinc formulation and a non. Very similar to when beta carotene originally, be bad in smokers because it could lead to lung cancer and other issues. They immediately started formulations that didn't have it. And so you're seeing that. And then in this last study, AREDS 2, it was not shown to be beneficial, so it was in essence removed. But because you have the choices that are present, I would look for a manufacturer that gave you that, so that when you're running your genetic tests, you can select the patients that you know are going to be best on the antioxidant formulation versus those who would be best on zinc. You also have the option of just getting zinc at some point. Even though I like the carotenoids, I think you can obviously just get zinc as a supplement. Usually comes in a 25 type milligram. And again, we don't know, as Carl said, if 80 is better or 20 is better. We don't have that information. We don't know if there's a dose response, but you could certainly get zinc as a supplement from any health food store. And in those patients, those that tested it being beneficial in slowing progression of the disease. So you really have all those options, the brands that we described. And there's variances. Not all have mesozeaxanthine, and there's discussion on that, but some of the leading experts really show that to be a great potential, kind of where we thought of lutein at 10 years ago. But they all have an AREDS type formulation, and most of them have a zinc versus no zinc option. And then, as I mentioned, for those zinc-only patients, you have carotenoids, but you could also do zinc supplements.
Right. But it is very important that the clinician consider which vitamin formulation to either bring into the office or make available for the patient online or via the telephone, so that they know which formulations that they want to dispense or recommend based on the patient report that can come through.
That's right. And I did a lot of research in all of those and talked to a lot of experts and people with far greater knowledge when I finally decided on the MacU Health. And I encourage you to do the same, to do your own research and make sure they have formulations that fit what we discussed tonight.
Yeah,
well, what you'll see in that list will be some of those formulations are very close to the straight AREDS 2 formula, and some of those formulations are more of a multivitamin approach. So depending upon what you're looking for, you need to, as Paul says, do your own homework there to pick the formulation you prefer. Carl, you were going to say something?
Yeah, I was going to say, we, without promoting any particular one, we looked through all the providers of an antioxidant only, that is a zinc-free formulation, and an AREDS 2 type formulation, and a zinc-only formulation. With the zinc, it's important that it's zinc oxide, that it comes with copper, so you really just don't want to send your patient off to the store saying, get some zinc. They may not get really the type that was used in the ARED study. And I wanted to have confidence that they were getting the right ingredients. And also, I felt good in that we were able to get a price for our patients in our office that I know is competitive, in most cases better than the over-the-counter product. So once I felt confident about that, I then felt really good about telling the patient, here's what I want you to take, and if you don't want to buy it from us, here's what you should take. Go find it in the store. If you can find it for less, that's okay, but we have confidence in this one, and the power, really, of telling the patient, your genetic test says that this is the one for you, and we have it here, and this is the one I want you to take, really is amazing. And I find that the compliance, at least in the short time that we've been doing this, seems so much better. The patients really know which one they're supposed to take, and they come back and it seems like the compliance is much better. So that's how we handle it in our office.
Thank you. Now, all of the data that you've presented, Carl, has been targeted on patients that present with intermediate AMD. And that's, again, the data related to the AREDS formulation and its efficacy is also targeting those particular patients. A number of the questions that I have in front of me are inquiring about patients that may have a family history, that maybe haven't presented with a diagnosis, and there are a variety of questions as to whether or not they should be tested, whether or not there should be a treatment, and whether or not those patients would have to pay for the test, and so on. So I'll just throw the concept open for either of you to address, this area where, as a company, we really don't have data to suggest that a patient that doesn't have AMD should be doing any of this, but obviously we do.
Right. I'm happy to touch on that first, I think. First of all, we'd love something that allowed us to halt the progression of someone with no AMD who's destined to get it from getting it. The problem is we don't know who those patients are. There aren't studies that are large enough to show that. So it's very important that in interpreting genetic risk in a patient with minimal or no disease, patients don't get a false sense of security or a false sense of anxiety. And so I always emphasize to patients that a genetic test is all about risk and not certainty. So, for example, if I have two people in a room, one tells me they always wear their seatbelt, the other says they never wear their seatbelt, we really don't know whether within the next 5 to 10 years it's the one who always wears their seatbelt who's injured in the car accident. But if you have 10,000 people who always wear their seatbelt and 10,000 who never, you feel very confident that there'll be more people injured in the group who don't wear it. And so patients need to understand that we're managing risk and not certainty. I think that we don't have data to base giving nutritional supplements to people with minimal or no AMD. But one of the reasons to consider a genetic test, I think, for those individuals is, first of all, if they are at high risk, it at least makes them more likely to get examined every few years at a minimum, so that if they begin to develop phenotypic changes, then, that's the patient that you really have to worry about. And the other big issue is, as Paul touched on before, it's been so common for us to say, well, maybe take these supplements. If they don't help you, they won't hurt you. And that's important. What you don't really want is to think that you've got a patient with a family history of AMD, and they say, I'm just going to start taking mom's vitamins to keep this from happening. And what if they fall into a genotype group that we ultimately know for sure is made worse by taking zinc or zinc in combination with other things? I will state that these recommendations, which I feel very confident in based on our analysis, are still based on an analysis of a single data set, the AREDS data set. So it's extremely high quality data. It's the same data that all of these treatment recommendations with the AREDS formulation are based upon, but we'd love to see, more a validating study one day. But I think just knowing that we can identify patients who shouldn't take these supplements is very valuable.
Well said.
Paul, any additions to that?
I can't. I mean, I have patients who, there are many patients we all have who have a family member, a parent in particular, who has gone blind from macular degeneration. So they do have they're very hypersensitive to it or vigilant on themselves. And so many will at a younger age and not show any signs want to know what their risk is. And of course, that's not covered by insurance in the U.S., but they would pay. But it is, I don't have any problem with that. I think sometimes it's great to know your genetic breakdown and your risk. But as Carl said, it's just kind of a guideline and gives you ideas. If I had a high-risk patient, MR4, for example, I would probably want to, start seeing that patient a little more often and maybe, give them an Amsler a little sooner than I would, even though that's not the most sensitive. It just seems like we're being proactive and the patients really do prefer that. And as Carl said, getting the genetic profile in terms of then the supplement recommendations can at least tell us what, might harm the patient, more so than considering, we put medications as an AREDS formula right away. So there's still benefit even in those patients, even though as a whole we haven't really studied a subset of patients that had no signs of macular degeneration in at least one eye that were of intermediate level. So we have to keep that in mind, but I still think the genetics would not change for that individual patient as time goes, I don't believe. And so they be consistent for at least future reference.
Okay. Thank you, Paul. I have just one or two more questions, and then we'll close up for the evening. We're running a little bit over time now. One of the questions is, does the person have to have AMD to do genetic testing?
Yes, so you don't have to do it. Of course, there's a reimbursement question, which I think Greg has touched on earlier, Paul did. And so in the U.S., you have to have AMD for insurance to cover the test. But if a patient really wants to have the test and wants to pay, that's different. And in Canada, I don't know the payment model. I think it's all patient pay. So the patient doesn't have to have AMD, but for all the reasons Paul just talked about and I did, I think that there's no real reason to encourage patients without AMD to get a genetic test, because the biggest risk factor for developing advanced AMD is having moderate AMD. So if you don't have any evidence of AMD, the genetic risk is really irrelevant for predicting progression. The reason it might be important, as we talked about, is you really at least want to stop people from, who are, maybe a little obsessive about their health, from taking a supplement that might be bad for them and that might, over the decades, increase their risk of AMD.
Great answer.
Right. Thanks, Carl. And I would, just to comment on the cost of the test in Canada, Milka Kouskas is the Vice President of Sales for the Canadian distribution company AMD Insight Inc. The maximum price to the doctor for the patient for VitaRisk testing is, I believe, $199, and for the full comprehensive macular risk test with the prognosis and the vitamin indication is $299, and I believe the prices go down from there depending upon the number of patients you're testing. So I know Milka will be around to address those kinds of commercial questions with any and all of you in Canada. And there, I'm just kind of scrolling through, and I think we've covered most of the questions. There's so many questions here, but they seem to be overlapping. One question about Medicare covering the test in the United States. At the present time, Medicare is reviewing coverage of all genetic tests, including macular risk and vita risk. But in the interim, the company is guaranteeing the insured service, so that the patient, that's a Medicare patient that has a diagnosis of macular degeneration, is covered with no copays and no deductibles. So the Medicare patient is covered in the United States. I don't know if there are any other last questions. I think we've covered the bulk of them. So it is now 9:16 p.m. and most of our audience is still on the line, and I thank you very much for your enduring interest this evening. And I would appreciate and thank as well Dr. Carl O. and Dr. Paul Karpecki for their excellent presentations and their responses to your questions. And I bid you all farewell and good night, and thank you very much. Thanks, Paul, and thanks, Carl.
Thank you, Greg, and thank you, Paul. Good night.
Good night, all.